Okay, let's transition. We've had a nice discussion on stage 3 disease and talked about a number of different issues. Let's kind of transition to stage 4 disease. And again, in my mind, stage 4 disease is first thing is to define any potential targets to identify those patients that are going to get greater benefit from targeted agents. And we have a number of targets and a number of approved agents. That's not going to be our focus today. One of the issues is if you don't have a target, then I do think the issue of chemoimmunotherapy is the topic we will discuss. I think all of us would agree that staining for PD-L1 by IHC is a standard of care in stage 4. And that what I wanted to start with is to kind of get Corey's perspective on those patients that are high stainers, greater than 50% is the benchmark we use, and what your thoughts are in that population.
That was a game changer. Marty Reck's original presentation at ESMO, and it's just 3 years ago. I mean, it's not that long.
It's actually October will be 3 years.
Yeah,
so it's less than 3 years.
You and I were there.
Yes, we were.
It was like the parting of the Red Sea, just so we could get in and give our talk.
And I had to do Checkmate 026 after that.
So about roughly a third of patients with wild-type advanced non-small cell have at least 50% expression. And Keynote 024 showed definitively in that population that single-agent, non-chemotherapy, pembrolizumab, far and away exceeded standard chemotherapy doublets, chemo du jour, with platinum. Progression-free survival improved on the order of about 4 months. There was a major improvement in response rate, and most importantly, a survival advantage that was detectable within a year, 70% versus the high 50s. And over time, as the data have matured, that survival advantage, if anything, has improved further. Median survival in that trial was 30 months, unprecedented figure for single-agent pembro, compared to about 14 and a half months for chemo alone. So the control arm was doing at least as well as, or better than it had done historically. Keynote 042, which was the plenary session last year at ASCO, I view as a practice affirming, but not practice changing. And that same cohort, and granted that was a trial that expanded to 1% or higher, but if we just look at 50% or higher, again, the positivity of that trial was driven by the 50% or higher group. Median survival, and the data are a little bit more mature at the initial presentation, about 20 months versus 12 months. You could argue it's a better slice of the real world. It was a more global trial. There were a higher percentage of folks with comorbidities and smokers, but nevertheless, including that population, major survival advantage. We've got to remember, Keynote 024, well over 1,600 patients were screened for PD-L1. The ultimate accrual was just over 300 patients. So there's a lot of attrition. A lot of folks do not qualify for these trials. There's a presentation here at this meeting that'll actually look at trial qualification. Probably 50% of patients that we see would never get on these trials.
Yeah, no, there's you know, I must say, ever since you first presented Keynote 21G, one of your many claims to fame, is you know, looking at the response rate of chemoimmuno in the greater than 50% rate. So, you know, there are many patients that, even though they stain highly, they, you know, particularly those patients that may be more symptomatic, that may have higher tumor burden and that sort of thing. I actually will use the combination of chemoimmunotherapy, even in the 50%.
Who have more fulminant disease.
Correct, yeah. Yeah. So how does this extend to less than 50%? Let me ask Heather. In the 1 to 49%, we saw this Keynote 042.
Right.
And your thoughts?
So I always emphasize looking for driver mutations, because I think in the community there's still now a push towards, oh, my PD-L1's back the next day, I'm just going to put them on immune therapy alone or chemoimmuno in that 1 to 49. So assuming no driver, the patient is 1 to 49.
Well, can I make just one point before you do that? I say whenever I talk about this that you should completely ignore PD-L1 status till you have the genomic testing back.
Exactly what I say to people also, and I think that's an important point. So it is important to emphasize that, because if you don't know, you don't know.
Right.
And I've had multiple patients where they were, you know, came to get a second opinion for me. They were teed up to get their immune therapy the next day because they had a PD-L1 of 70%. I said, wait, you're a never smoking Asian person who's 50 years old. So that was obvious, but there are others where it's not so obvious. And I think a couple people had ALK. That would have been a very bad choice for them to go on single agent immune therapy. But getting back to your key question, for patients without driver mutations, if they have a PD-L1 of 1 to 49%, I give them chemoimmune therapy unless there's an absolute contraindication to them getting chemotherapy. And very frail patient, or where we are in California, lots of people absolutely refusing chemo, and I can be pretty persuasive.
I would hope so.
Can be pretty persuasive, but sometimes we can end up in that setting. So we will talk about the data, but I will tell them that immune therapy alone, to me, if they're not higher than 50%, the probability of that working is quite low.
One of the problems I have with that is, to Corey's point, those patients wouldn't have been allowed on the trial.
If they're really frail, they would have been PS2 most likely, and they theoretically could not have been enrolled.
Right, and I worry about the activity of immunomonotherapy in those populations.
So it gets. I'm thinking I have a patient I started last week, who was one of those patients where you meet her, she's not looking good. By the next week, she's looking much worse. Where you can almost see the cancer growing, right? And so she was someone where we were waiting for the driver mutation. It was a never smoking woman in her 60s. Tested outside, so I only had my ALK and ROS and EGFR, and those came back like the day before I had her set up for chemoimmune therapy. Her performance status was definitely a 2 by the time we started, but she was someone where I knew that performance status had gone down solely from her disease. So just like in the small cell setting, where we've known for a long time, if they're going down because of the disease, you're going to push your chemo window beyond what you might do in a trial. And so, but for other folks where older, frail anyway, that's where I think about immune therapy maybe in that 1 to 49%, but I tend to try to encourage chemoimmune therapy in that.
Yeah, and so just to be aware, in the exploratory analysis in the 1 to 49%, it did not achieve statistical significance. And I still struggle with this cut point of 20%. I don't know if our pathologists are that good at figuring out whether it's 20%. That seemed to be, if you were higher, that hasn't influenced my practice. Any others?
No.
And there are some patients, I think we'll get to this a little bit later, but PD-L1 for those particular trials, that was the marker, but we know it's not the whole truth.
Right.
It's not like when you find an EGFR mutation and that's the truth. There's grays, there are shades of gray here that we don't fully understand. So there are some patients that are still going to have a response who don't have PD-L1, and that's where in that 1 to 49%, I don't feel like it's a terrible choice in the right setting, but with the full disclosure conversation.
Right, and I've always been concerned about what I refer to as the early dip phenomenon. Each of those Kaplan-Meier curves on 042, all those different subsets, there's an early disadvantage to immunotherapy, and I just don't know how we identify those patients, from day one to do that.